So we proceed to the case discussion. So this is the scenario. First of all, this is Mr. H, a 72-year-old Malay man, widower, who is also a pensioner. He has been having this diabetes, hypertension, dyslipidemia for the past 10 years. He comes for the routine checkup and accompanied by his son with no active complaints. His current medication are metformin, glycoside, atorvastatin, enalapril, as well as amlodipine. So physical examination showed that he was pink, he was comfortable, his weight was 88 kg, slightly overweight, the height was 165 cm, with a BMI of 32.3. And his PP was normal, 130/80, pulse rate was 78. And other systemic examinations are unremarkable, no pedal edema. So these are the blood investigations, right? Cholesterol high, then creatinine, urea, sodium, potassium, all normal. HbA1c high as well. And the urine microalbumin was normal. So question number one, what further history would you like to ask? So what we need to do is we need to look at the previous HbA1c reading. Then we have to see whether the patient has been compliant to the treatment and try to find out whatever possible side effects of the treatment because of all this, because patient is on multiple medications, polypharmacy, very easily they have these side effects. Then person who lives with the patients is very important as well. We try to get as much as history from them. And we also assess them, assess the caregivers. We also get as much as a social background in the history taking. And also we need to rule out any acute infections that are going on for the elderly patient because they are very commonly get infected for chest infections as well as urinary tract infections. As the patient is a diabetic patient, so the previous HbA1c was 7.3, all right, earlier this year. Then patient claims that he has been taking the medication very regularly. No history of recent infection, no previously worked as a site manager. He was smoking in the past, stopped last year. And he doesn't consume alcohol. He lives with his son and daughter-in-law. So question number two, what would you like to clarify from the son? If let's say you are given a chance to interview the son, which we usually do in our what we call interview. We interview the patient as well as the family caregivers, especially the immediate caregivers, those who are living with the patient. So again, we need to clarify on the compliance to the medications. So history from son was taken, then we found out that he frequents forget to take the medication. He asked for food repeatedly even after he just had it earlier, and easily become confused when he get placed in a new environment. Let's say he goes out or he moved to another house, because usually the family with a patient like this, they used to be rotated by the caregivers when they're coming to the care. Then he's still able to remember well of his past family events, However, he struggles with the recent events. He couldn't find his belongings because of misplacing it. That has been going on for the past 1 year, apparently. And the son claims that his father's memory is gradually worsening. So what other history do you need to take? So we need to determine not only the cognitive part, we also need to know the functional status of the patient. Like we have to go into the basic ADL. What can the patient do at home? Things such as eating on his own, going to the bathroom, right? Passing motion, passing urine. Can the patient clean it up properly? Then you go to instrumental activity of daily living. Things like mentioned by Dr. Tay earlier, like cooking, like driving, using money, going to the bank to withdraw money, using a device like phone, right? Operating simple electric device like a TV using a remote control. So we also need to dig out all these psychiatric symptoms, the patient's mood, all right, whether he or she was depressed or not, or any psychotic presentation, hallucinations, delusions, as well as the behavior like agitations, right? So this is another case. So patient is independent with basic ADL, so he doesn't need anybody to help him up for the basic activity of daily living, but he struggles with instrumental activity of daily livings. He got problem while using the TV remote control, right? And he doesn't know how to pay his groceries, right? Even though things like all these things usually is being handled by somebody else, especially the caregivers. And he also has other issues like he felt lost while driving and had a minor accident. Minor accident here means sometimes they are losing their uh, sensitivity, um, their I mean, when let's say the car needs to brake immediately in front of the traffic lights, they just couldn't handle, all right, the, the brakes when they are driving, or when they are parking, they have scratches over the cars because of all these minor accidents. He didn't have any depressive mode or depressive symptoms, and he always feel nervous, anxious when he couldn't perform his usual tasks. So what examination should you do? So obviously you can do physical examination, you can do mental state examination as well. And we found that during the physical examinations, there was no neurological deficits, no Parkinsonism kind of features. Then a cognitive assessment was done, noted to have this score of 2 for Minicock, 18 for MMSE, right? And the geriatric depression scale was 2. So what investigation should you do? Blood investigation, okay? Like mentioned earlier, full blood count, your liver function, rapid the renal profile, fasting sugar, fasting lipid, thyroid function test, the serum vitamin B12, folate. Then if you need to do syphilis screening or HIV screening, depends on the history of the patient, please proceed. Then you can do brain imaging, either CT scan or MRI. So noted that lab investigations was not normal. Then now what is your provisional diagnosis? So we put up as dementia or major neurocognitive disorder. And we have to exclude other mental disorders or other dementia mimicking conditions such as hypothyroidism, vitamin B12 deficiency. That's why we have to do all these blood tests. Folate deficiency, hypercalcemia, syphilis, HIV-related dementia, or even diagnosis like normal pressure, hydrocephalus, subdural hemorrhage, tumor in the brain, CJD, autoimmune, limbic encephalitis. So what will you do next? So we will usually, at the GP level, we will refer them to the tertiary hospital or the nearest hospital with the facilities of psychiatric service, to psychiatrists, neurologists, geriatrician, or even physicians for the further management. So he is seen as the nearest hospital diagnosed with Alzheimer's dementia. Then he started on donepezil and referred to occupational therapists for cognitive stimulations therapy. He continues follow-up under the hospital. After 3 months, the patient presented again to you with a sudden change of behavior and increased confusion for the past 3 days. He's not sleeping at night and not eating well. What should you do now? So we usually need to rule out the patients with this diagnosis of delirium. All right, we can take history of any reason, infection, fever, cough, urinary symptoms, etc. Then we take other history like falls, possibility of a stroke, CVA, check for potential inappropriate prescriptions. So he had fever, he had running nose, he had coughs, coughings for the past 3 days. He was given paracetamol and Piriton by family members. Then physical examinations and investigations diagnosed to have a chest infection, pneumonia with possibility of delirium. And we have to stop medication like Piriton. And we refer the patient to hospital for the further management of this infection, which lead up to delirium. So in this list, which you can get it in our CPG Dementia third edition, you're most welcome to download this from the Academy of Medicine website or from MPA website. So you can see a lot of these medications. You have some of the medications like the neuro medications, right? Hypertensive medications, medication for pain control, medication like antihistamine, etc., which contains a lot of cholinergic, anticholinergic effect, which will make the patient becoming more and more confused. And the patient continues with his follow-up at the GP for his diabetes and hypertension. And the son complained to you that he was stressed and burned out with the care of his father. What will you do next? So again, like what I said earlier, you are not only seeing the patient with dementia, you also need to see the caregivers, assess them, support them as well. So we assess the caregiver burdens using SARIT, burden interview scale. And we refer for caregiver training and psychoeducations, as well as we try our best to introduce this respite care for the caregivers to help up the caregivers. So thank you very much for your attention.